Good afternoon, friends. We are going to discuss about preconceptional workup in consanguineous couples. So, what is consanguinity? Consanguinity, we all know, consanguinity means related by blood. It is defined as union between persons who are biologically related as second cousins or even closer. Approximately 1.1 billion couples currently living in countries where consanguineous marriages are customary, and among them, one in every three marriages is between cousins. In India, consanguinity is more seen in southeastern parts of India. So, here, one or more ancestor is common, and there is no more remote than great grandparents. So, what are the degree of consanguinity? So, we have first degree, second degree, and third degree cousins. First degree is between incestuous union, like father and daughter, mother and son. Second degree is uncle and niece, and these are also known as double first cousins. Third degree is first cousins, and fourth degree is second cousins. So, anything which is closer than second cousins means fourth degree cousins, third degree cousins, second degree, or first degree. This is known as consanguineous marriage. So, looking at this chart, this is about gene sharing, where first cousins share around 1/8 of their genetic material. Second cousins have 1 in 32, and double first cousins or uncle niece shares around 25% genes, and around 50% genes are shared between first degrees or father son, father daughter. So this is the pattern. Now, what is the impact of consanguinity? Consanguinity and reproductive health. More than 90% of consanguineous couples have normal babies. Fertility rates are even higher in consanguineous marriage. There is no significant difference in the paternal loss rates. Consanguinity and birth defects. So, consanguinity can be associated with congenital malformations, genetic disease, and disabilities. So, what is the association between consanguinity and congenital anomalies? In general, congenital malformations are 2 times higher, means 2x they are more than non-consanguineous couples, and 4 to 6% of consanguineous couples compared to 2 to 3% of normal population. Another estimate states that the risk is around 1.7 to 2.8% higher, means around 2 times. So there is positive association between parental consanguinity and congenital heart disease. So what diseases are more in consanguineous couples? Congenital heart diseases are more commonly reported. There is association between neural tube defects, cleft lip and palate have also been reported but needs further research. Now, what is the association between genetic diseases and consanguinity? There is no association between chromosomal disorders like Down syndrome. So, in consanguineous couples, risk of Down syndrome is less. The association is more with AR increase. AR means autosomal recessive diseases have increased risk in consanguineous couples, and effects are more pronounced for rare disorders. So, what is an autosomal recessive disease? Where there is one dominant and one recessive allele, and when both parents have recessivity or autosomal recessive features, then one child or 25% of the cases may have affected sibling. So, the dominant allele have masked the phenotypic appearance of recessive allele, which is involved in disease causation. So each sibling of an affected person has a 25% chance of being affected, and 2/3 of non-affected children are carrier. That is 50% babies are carrier, 50%, 25% are affected, and 25% are normal. Consanguinity and disabilities. The disabilities are over representation of offspring of consanguineous parent. Reason because good proportion of these are due to autosomal recessive conditions. Common disabilities associated with consanguineous marriages are mental retardation, blindness, deafness, mutism, and severe intellectual disabilities. So, how will you work up in an consanguineous couple? Situations in a consanguineous marriage. Either there is history of known genetic disease in the family, there is an identifiable genetic disease in the family, that is history of sudden infant death, and there is no known or identifiable disease in the family. So either disease is known, either disease is identifiable, or either disease is unknown. So crucial first workup in couples in detailed history and 4 generation pedigree. So we make a 4 generation pedigree. So look at these images. So till this there is third generation, and this is the fourth generation where this pregnancy is under question. This fourth generation and this pregnancy is under question. So this is a generation pedigree that we make for the workup of preconception marriages. So if family has a known genetic disorder, and if the pedigree reveals that the couple could be a carrier, then we refer to the geneticist for career information. History of no known genetic disease. Specific questions are asked from the couple or the family. Presence of any of the following in the blood relatives should be asked, like presence of congenital anomalies, hearing defect, vision defect, mental retardation or learning disabilities, developmental delays or failure to thrive, inherited blood dyscrasias in the families like thalassemia, unexplained death or infant death, epilepsy, undiagnosed severe illness. In families with any of these suggest probable genetic disorder, and here also we refer to the geneticist and ask for risk assessment or the career information. There is no known or identifiable genetic disorders. If the couple does not have any genetic disorder after detailed workup, then following is done. Either you can do carrier screening. If positive, then refer to geneticist, or if carrier screening is negative, then we can counsel the risk of consanguineous marriage, and closer consanguineous couple poses a higher risk. Means more closer. Carrier screening. It is done in ethnic groups with higher carrier rate of genetic disorders, universally done in all consanguineous couples. After carrier screening, we divide the family into targeted screening and expanded carrier screening. Targeted screening, this carrier screening can be done to detect certain anomalies which are targeted, like thalassemia, spinal muscle atrophies, fragile X syndrome, cystic fibrosis, and Duchenne muscular dystrophy. While expanded screening includes studying around 1100 genes, 2500 genes, 3200 genes, and exon screening, where expressed portions of genes are studied. So what are the drawbacks of carrier screening? There is variance of unknown significance, which is difficult to distinguish between mutation and a pathogenic mutation. Not all mutations are bad. There are certain mutations which are good and a part of evolution also. So time factor, all these tests of carrier screening takes times, and these are very costly. Turnover time for most genetic tests would be around 8 to 10 weeks. So what are the wrong concepts about preconceptional workup? So some doctors do what they do. They refer the patient in the preconception period, where patient is not conceived, he is just planning for pregnancy. So this should not be done. Refer to the couple to the genesis. So this is done. Yes, we should refer the patient in the preconceptional period so that we can do carrier screening, we can do karyotyping of the patient, and other certain tests can also be done. History and pedigree analysis and proper workup can also be done. So some doctors do, they refer the patient at 12 weeks of pregnancy, where the present pregnancy cannot be dealt with. It has already been taken till this gestation. And what another thing is done in a wrong way is do a karyotype to rule out the possibility of genetic problems. So karyotype means chromosomal abnormality detection. So chromosomal abnormality is not associated with consanguineous marriage, so it cannot rule out genetic problems, hence karyotype is of no use. Refer to amniocentesis and genetic testing without knowing the exact diagnosis in the family. So they miss index workup and then they refer to the geneticist, so this is also not to be done. Then what is the inheritance of birth defects? So birth defects can be unifactorial, like autosomal dominant, autosomal recessive, X-linked and mitochondrial. They can be chromosomal birth defects also, like numerical aneuploidies or structural abnormalities, microdeletions and duplications. They can be multifactorial also, and there is environmental factors in utero and unknown cause. So these are the causes of birth defects. Consanguinity increases the risk of autosomal recessive disorders, as we all know. There is no association of consanguinity with autosomal dominant, dominant, X-linked and mitochondrial inheritance. Chromosomal disorders such as Down syndrome is also not associated with consanguinity. Then how will you work up in a consanguineous couple? First of all, we see the pedigree or the fourth generation pedigree, where we detect the genetic disease in the family. If the diagnosis is not known, refer to the specialist for diagnosis and determine specific additional to 4 to 6% for the first cousin couples. And if there is diagnosed autosomal recessive condition, then we refer to the specialist. Counseling and test for carrier status is done, and if positive result, then we attribute a risk in addition to 4 to 6% for first cousin couples. And if results are negative, that there is no carrier status, then 4 to 6% is risk is given. Then pedigree construction is done. There is no genetic disease in the family. Specific questions are asked, and if there is probability of genetic disease in the family, then we refer to the geneticist. If no genetic disease in the family, then carrier screening for common autosomal recessive diseases is done, and based on negative and positive result, we attribute risk to the family. So this is the preconceptional workup in a consanguineous couple.